Good morning for those that are here statewide, and good afternoon and good evening for those in other parts of the world. My name is Pei-Ting. Thank you so much, Preeti, for the introduction. Thank you for joining us here today as we share with you on the topic of assessing outcomes across a continuum after stroke. Next slide. For the objective of this talk, we will be discussing the importance of utilizing outcome measures across the continuum of care, describe the process of selecting outcome measures, and discuss the implementation process of outcome measures into clinical practice, and finally, to describe the audit process and data feedback measures to assess and improve compliance. So, we don't have any conflict of interest or financial disclosures. And to start, both Shauna and myself will begin with the question of why are standardized outcome measures important across the continuum of care after stroke? So the assessment of recovery is not only important in a research setting, but it is critical to define in a clinical setting as we want to better understand about the mode of intervention to assess its impact on recovery. Outcome measures can help define specific impairments, and once an impairment is identified, it can assist in clinical reasoning for treatment planning. We can use different modalities for therapeutic intervention. However, modalities for intervention can vary from clinician to clinician and institute to institute. So how do we know what are the most effective treatment modalities? For that, we need to standardize outcome measures to speak the same language and to compare apples to apples. Next slide. So to date, the best framework for stroke outcome measures is using the World Health Organization framework for health and disability. This is also known as the International Classification of Functioning, Disability, and Health, or the ICF model. This framework captures the entire person rather than just focusing on a single aspect of a patient. Measurement of recovery at just one level gives only a partial picture of the entire recovery process. And there are 3 levels defined by the ICF. First level is defined by the impairment, where we're looking at the body function and structure. Second is activities, which is defined as execution of a task or an action by an individual. That function or functional task can be walking, talking, toileting, or eating in the context of a patient's daily living task. Third, participation is defined as involvement in a life situation. Both activities and participation is impacted by a patient's environmental and personal factors. So to be more specific, environmental and personal factors are shaped by social and familial support. Early family involvement is strongly correlated to patients' adherence to therapy. It also assists better understanding between patient and caregiver of achievable outcomes, as well as improved communication between patient and caregivers. So using the ICF model that measures stroke recovery at the impairment, activity, and participation levels, it allows us to determine how changes in impairments can then impact on changes in the activity and perceived quality of life. Next slide, please. And the other consideration for outcome measure selection would be the psychometrics properties of an outcome measure. The essential properties are reliability, validity, responsiveness, and sensibility. A change in score in health status or quality of life measure may be of little clinical or practical importance. It is more important to know the minimal clinically important difference or the MCID. So it is worth knowing whether an observed difference indicates a clinically significant or a trivial effect on the patient's health status or quality of life. Therefore, the smallest difference in a score that is considered to be worthwhile or important should be considered in outcome measure selection to assist clinicians in guiding clinical practice. And next slide. So we encounter a few challenges, and the challenges in selecting outcome measures can be multifactorial. Each patient presents uniquely upon their etiology of stroke, severity of their stroke, and the location of the stroke. And this makes it very difficult to select outcome measures due to the heterogeneity of the stroke patient population. Additionally, we needed to consider the possibility of spontaneous recovery after stroke that can also cloud the picture. So how do we know if what we're doing is working? At the moment, different studies look at treatment for stroke impairment, often use different outcome measures. We are often comparing apples to oranges. As an example, one study can be utilizing the modified Rankin scale, while another might be using the Fugl-Meyer to define impairment after stroke. So to fix this problem, we need to define a core outcome data set. While there has been some consensus on outcome measure selection, there has been poor worldwide implementation. So for example, in 2020, a consensus paper published by Pohl et al. Was published that defined the core set outcome measures for clinical motor rehabilitation after stroke. However, institutions continue to define their own set of outcome measures, further propagating the challenge. So to illustrate the challenges and proposed solutions, I'm going to take you through our Johns Hopkins experience at the Sheikh Khalifa Stroke Institute. Next slide. The development of our standard assessment battery involved the selection of measures to be included in the battery, as well as the discipline that will administer the assessment and the time frame for administrating these outcomes within the battery. So as clinicians, we often struggle with the time requirement of administering the outcome measures as a potential trade-off to providing therapeutic intervention. So at different time points of recovery, we were concerned for use of outcome measures with the potential of ceiling or floor effects. So different outcomes are designed to capture different aspects of recovery at different timeframes. Thus, we needed to be thoughtful when selecting outcome measures that would provide utility throughout the entire continuum. And additionally, depending on patients and therapists' locations, there were potential for a short length of stay, such as acutely after a stroke. Thus, selecting time-consuming outcome measures was a big concern for therapist compliance. So for the physical therapy team, we consulted with the recommendations put out by the Academy of Neurologic Physical Therapy. For the occupational therapy team, they consulted with the occupational therapy practice guidelines for adults with stroke, as well as stroke recovery roundtable. And for the speech therapy team, because they address many domains of function, specifically swallowing, cognition, language, and motor speech, the team came up with a screening tool within each domain of SLP scope of practice, which Shauna will share with you more in a few moments. So we may go back a couple slides, but to illustrate the selected outcomes in the physical therapy side of things, we selected 7 outcome measures shown on this table. The team addressed any potential floor and ceiling effects, creating rules of scoring and administration to increase the feasibility of using some of the measures across the continuum of care. Now, for the occupational therapy side of things, the team selected 8 outcome measures, and as depicted here in this table. Now, it is important to note that occupational therapy addresses several domains of function, such as motor skills, vision, and cognition. So the functional assessments in the standard battery shown here really is focusing just on upper limb function and activities of daily living. And this decision was made to maximize the feasibility of the battery. So now I'm going to pass it off to Shauna as she shared with you about the speech language pathology team.
So for the speech team, there were additional challenges that made it hard to come up with one standardized set of outcomes that every patient would get, given the nature of the impairments that we can treat in our scope of practice. So there are 4 different domains that we treat, and in that initial evaluation, a lot of clinical decision-making is happening to determine what next steps are, what evaluations we need to proceed with. So in order to try to streamline some of that clinical decision-making, we decided to come up with 4 screeners for each of those domains. And those would be completed in the initial evaluation in just about under 10 minutes, so very feasible. And based on how the patients would perform, if they scored less than a cutoff score, as listed here, then we'd proceed with the outcome measures for that domain of impairment. So next slide. So these are the outcome measures we decided on for cognition, language, and motor speech. You can see that most of them are completed at all levels along the continuum of care. There are a couple exceptions. So you can see the RIPA G has some asterisks next to it. That is an alternative cognitive assessment that we may use in acute care only if a patient, for whatever reason, can't complete the R-bands. The R-bands is a little more visually based compared to the RIPA G is auditory based. So depending on what deficits the patient is presenting with, you may make a different decision there. Another exception would be the ACOM, which is like a functional communication type screener. And it's looking at the patient's activity and participation beyond the medical setting. So that was more appropriate to tackle on the outpatient level once somebody has resumed their everyday skills. Next slide. And these are the outcome measures that we decided on for swallowing as well. Again, the only exception here is the EAT 10, which is only given in the outpatient setting. Again, looking at more of that participation level that somebody who's limited to the hospital setting in acute care and rehab may not be able to complete. Next slide. So as Pei-Ting alluded to, we had several considerations in making these decisions. One big thing being time. So there's obviously a trade-off between completing skilled treatment and also completing outcome measures. The outcome measures are what we needed to inform our treatment, but we wanted to make sure that that didn't monopolize all of our treatment time. So in the acute care setting and the inpatient rehab setting, we're limited by short lengths of stay. So we wanted to make sure that we had a balance of getting the information we needed, but also being able to provide the treatment early, as we know that's important for our patients' recovery. Another consideration was the time of the therapist. So we wanted to make sure therapists were able to comply with our recommendations in completing these outcome measures. So they needed to be feasible to complete within the time constraints innate to our setting. Additionally, we needed to consider what was feasible across the continuum of care. So you could see the majority of the outcomes that we landed on were appropriate across the settings, but there were a couple exceptions as well. And also, as Pei-Ting mentioned before, we had to consider some of the ceiling effects that we may have at different levels of recovery. So making sure that we were choosing those outcomes that were sensitive to the recovery that we were looking at. Next slide.
So my name is Jessica. And I'm the rehab team coordinator of the therapy team in acute care. So I'm going to be speaking about the implementation process that we use specifically on the acute care side to roll out this outcome measures. So our plan consisted of these key areas: the development of resources, equipment for operational workflow, optimizing documentation for the electronic medical record, and education. You will hear education mentioned many times throughout this presentation. Next slide, please. So once the outcome measures were determined through the process that Pei-Ting and Shauna just described, it was important for us to create a resource manual to act as a reference for all team members. This gave us confidence that we were all following the same standards and set of rules. The resource manual was saved both electronically on our iDrive and also physically in our rehab gym close to patient care units so that it was accessible for day-to-day operations. Once it was created, it also served as a manual for training new team members that came on. Next slide. Another aspect of the workflow was the importance of equipment. We needed to be consistent across the continuum on the brands of equipment that we used, and also make sure that each area had the right amount of equipment so that therapists could use it for what they needed it for. Some examples were the grip dynamometers, stools, and items for the Berg balance assessment, as well as items for the FMA. We chose items based on the parameters set by the creators of the tests to ensure the validity of our results. and then also look to clinical experts in all three settings to determine the best option. Therapists needed to have access to the items in order to make outcome measure administration feasible. So we placed items in both the neuro ICU and on the step-down brew units. We also had markers in the hallway, thanks to our nurse manager friends that allowed us to do this for the 10-meter walk test up on the floors so that therapists could literally take patients out to the hall to complete an outcome measure pretty easily. Next slide. Another aspect of feasibility was the documentation of outcome measures in our notes and in our communication and schedule. In the acute care setting, handoff between therapists is important as it can really change from day to day. We needed to make sure that a therapist picking up a patient would be able to identify the outcome measures that were already completed and those that were due so that they could be completed within the time frame that we had chosen. So you can see here on this slide, there were multiple processes that were created within Epic, our electronic medical record, to include a tab to document the outcome measures battery, a synopsis where you could see the most recent value of all the outcome measures in one place, a link to pull it into notes. And we also use therapy scheduler within Epic to aid in communication between therapists. And I will show you visuals of all of these things later on in the presentation. Next slide. Ongoing education was the most important piece of the operational plan. We set up joint trainings for therapists in all three settings for implementation of the outcome measures. These forums addressed any knowledge gaps to ensure consistency and accuracy. We also had education on how to use the Epic bundles and when and where to document all the information, as it was very different than our previous workflow within Epic. So education was continuous during the first year of implementation to address all of these areas. Next slide. So these are where the fun visuals come in to give you an idea of what I'm talking about. This slide shows the addition of the SKSI bundle tab in the navigator, and that was created for documentation of the discipline-specific outcomes. So this slide is showing one for PT, but it existed for all three disciplines. Next slide. So once the therapist clicks on the tab, they can see all of the functional and impairment-based outcomes for their discipline and are able to document the scores. They can also use this flow sheet to look back and see if an outcome measure was completed on an earlier date in the patient's admission. Next slide. And so the synopsis feature is very helpful. If a patient is being followed up by a new therapist and they're unclear of what outcome measures have been completed. So within the chart review tab, you can click on the synopsis. Next slide. And then it pulls up this flow sheet, and the therapist can choose their discipline and can see the last entered values and the date of when the outcome measures were completed. And this can be used across the continuum. So a patient that is seen by myself in acute care then goes to outpatient. Pei-Ting could look at this flow sheet and see the date of when the Fugl-Meyer was last administered. Next slide. So this slide, I know it's a little bit on the smaller side, but it's a timeline looking at the big picture of the operations from when we went live with outcome measures on acute care. So you can see from January to June of 2021, that was the time period that really Pei-Ting was talking about, where we harmonized and finalized the outcome measures across settings and where we educated the staff in preparation for implementation. July 1st marked when we had the therapist begin implementation of these outcome measures of the battery using just existing flow sheets in the electronic medical record. And then when you look forward to the next 2 months, we were gaining feedback from staff and identifying barriers, which led to changes in our rule set for timeframes and lots and lots of communication to clarify, modify, and hone our operations moving forward. September 15th marked when the Epic bundles went into effect, which was very nice because then it increased the ease of documentation for therapists and allowed for more feasible data collection, which Samia will now talk a little bit about the data collection.
You're muted, Samia.
Sorry about that. So I'm Samia Kumble. I'm a clinical resource analyst in acute care, and I manage and direct the quality improvement and the clinical research projects for our acute care. So, Pei-Ting and described how we chose the outcome measures across the continuum of care, how we came into a consensus on what outcome measures to use, and just gave an overview of like how this was implemented in the acute care, and similar processes were followed in our inpatient rehab setting as well as in the outpatient rehab setting as well. And so when we started looking at once the implementation of the outcome measures administration was put into effect, we used a systematic approach throughout the whole process. So that's why what just showed us in her timeline, you can see that systematic approach that we used. But once we had the implementation, the staff were educated, the resources were created, the electronic medical record system was also adapted to help the clinician administer these outcome measures according to the rule set that we have put in on like what days they need to be completing these outcome measures. Started looking at the compliance of the administration of these outcome measures. And so, so this is the TRIP model, the translating evidence into practice model. And you can see that a lot of those once we got into the stage 4 here, we kind of like started, it's a circle. So we kind of started evaluating the process and then use that information to re-engage the staff, re-educate the staff, execute changes, and then continue. And ongoing evaluation was part of this process here, what we term as the 4 E's of the TRIP model. So again, the data feedback is important when we are, in clinical practice, so that we can identify the barriers and the gaps. We can engage the bedside clinicians to be part of that, to identify the solutions, and so that we can implement the appropriate strategies to improve our performance. So what we used here is like, what can we do better and how to improve our process? What can we do better to improve the compliance with administering the outcome measures, instead of using the data as a punitive approach. So that is very important, especially to engage your staff when you are implementing a QI process as well. So when we started collecting the data to track the compliance of the administration of the outcome measures for PT, OT, and SLP, we did audits to measure the compliance, and we had rules that as we were doing the audits, we had these rules set of like in acute care, some of these measures have to be completed over a certain time period. And so we followed those rules that we worked with the clinicians and as well as like Jess and Shauna to kind of make sure that what we are looking in terms of the data extraction or audits is also like what is happening bedside as well. And the neuro residents, the PT residents has played a major role in helping with these monthly audits that we did and summarizing the data and sharing that with our team to look at the performance here as well. So as you can see here in the timeline that just showed earlier here, so that first 4 months was all the processes that Peyton, Shauna, and just described. And then once we started doing the audits in the October of like 2021, and then we we shared that with, again, the leadership team, the bedside clinicians during the staff meeting, so that we can really kind of like the bedside clinicians, we really wanted the bedside clinicians also to see what they are doing and how that is reflected in the data as well. And so this is just an example of the data, the audits that we did and the data that we collected. But at the same, these are the first few months into the audit process as well. So this helped us to understand like why certain outcome measures were completed at above 75% of the time, and why certain outcome measures were, there was not that compliant with some of the outcome measures as well. And similarly to the OT outcome measure 2, we used those outcome measures that they were supposed to do that Peyton had mentioned earlier. So we looked at the trend with the compliance with that as well. And for speech, we were looking more of like completing the compliance with completing the screeners as well as the outcome measures that they were supposed to do once the screeners were completed as well. So this is kind of an example of like how we kind of like track that for the first few months. And then we went back to like after those first few months of tracking, we, and sharing it with the staff, with the leadership, we were able to understand the barriers. We were able to, and this is where I was saying that engaging this bedside clinicians is so important, because at the end of the day, they're the one who implement, they're the one who are treating the patients, they're the one who can utilize the information that we get from the outcome measures into in choosing the appropriate interventions for their patients as well. And so so that was the that's how we used our data here. And then I'm going to hand it over to Jess to talk about the challenges and the strategies as well.
Sure. So this chart is kind of summarizing the challenges we identified during our process and the strategies that we employed to address those challenges. We have mentioned this many times, but feasibility, especially in the acute care setting, was one of the most identified barriers by both leadership and the bedside clinicians. So we wanted to support those therapists with the limited time that they have and barriers that have to do with the patient caseload, medical tolerance, caseload demands in acute care, and the environment that they're doing these outcome measures in. We really wanted to think about the environmental demands as far as being able to do specific outcome measures in an ICU room, for example. It's a little bit different than in a clinic setting. So we discussed all the three strategies here that we to address those elements: the documentation, really the location of items and resources, and that communication and feedback. And with the beautiful graphs that Samia showed, what we would do when we would look at these monthly is we would see if there was one outcome measure that was, we were struggling with, that we didn't have high compliance. We would really look at it critically and say, for example, why was the Berg balance scale so low this month, or what barriers might be there, and get feedback from the therapist about it. And it might have been something as simple as, we had a very high caseload that was in the ICU this month, and the items for the Berg are all the way up on the 12th floor versus the 3rd floor. So maybe we need to have those items closer so that it's more feasible for the therapist to use. It could be something that simple, but having that data available monthly to really look at it in those terms was helpful to make those little tiny adjustments. The second challenge that we wanted to address was competency of the staff to administer the outcome measures that were not primarily in their toolbox for this setting. So the one that comes to mind is the Fugelmeyer assessment. We've grown to love-hate this outcome measure over the years. It's not one that our therapists in acute care really used on the daily. So we did a thorough training for our PTs and OTs so that they felt, confident and competent in doing the outcome measure, and that helps with compliance of administering it. And lastly, the staff buy-in should always be considered. Samia mentioned this before, when starting a new initiative. So it was really important for leadership to give the big picture why are we doing this? Relating the administration of these outcome measures to the overall goals and vision of SKSI, and how they really benefit the patient by guiding our plan of care and treatment interventions. Our group of therapists is awesome in acute care, and I know it's the same in outpatient and in rehab, but they really want to know that they're doing best practice. They want to know that they're helping the patient. And so as soon as we kind of bridged between, we're doing these outcomes to really guide what our treatments are, this is going to help the patient, we aren't just checking a box. All of our staff was engaged and wanted to do it because they saw what the value was, and they saw that what they were doing was helping the patient in their recovery, and that could lead to more data in the future, which I think further talks today are going to talk a little bit about as well. So the recurring theme for all of these challenges was really communication and feedback. Samia mentioned this, but the therapists, the bedside clinicians that are performing these things, being included in the process and having input into the workflow was key, because they knew where the barriers were. They knew why certain outcomes were more difficult than others to perform. And so engaging them in the process and having them at the table when these decisions were being made was really important.
Thanks, Jess. And so, like just mentioned, that education and engagement and, implementing, like listening to the bedside clinicians and implementing some of the ideas that they bring forth has been really helpful in acute care setting for us to kind of like push, improve our compliance with the outcome measures. And these feedback were again given from during the one-on-one. We need to look at like all the different avenues where we can kind of like go share the data and ask for feedback and ask for solutions as well. So, and the other thing that Just also has mentioned here, is the ongoing education is really important. Giving that refreshers like, every 3 months, every 6 months, that was also important for us, especially given that we started this back in like that 2020. And with COVID, time went by so fast as well. And so we continue to track the compliance and share the our data monthly with our staff, but using these 4 approaches. I just wanted to give you, show you an example of like now, since that 22 of January to 23 of like April, we can see that there are 2 graphs. This is a PT outcome measure summary that you see here. But on the left-hand side of the graph that you can see, this is like when the outcome measures were completed within the window. Yes, there are times or months where some of these outcome measures dropped, and then that re-education took that back to, like, you can see that, for example, the MMT, when it dropped, it went back up to 100% the next month as well. The other thing that we also did was that not only just looking at the compliance with the outcome measure trends within that done within the window of the time period in acute care, but we also wanted to make sure, see if it could be done even outside of that window, because at the end of the day, what is important is that that patient has an outcome measure or that a baseline assessment using outcome measures at least once during that initial stay. So we get that initial baseline assessment, and then when they continue with their stroke recovery journey in the inpatient rehab or in the outpatient setting, we have something to compare against as well. So on the right-hand side of the screen, you can see that when it was done outside of the window, there was, we had a lot more compliance as well. So at least these patients received those, baseline measurement at least once during their hospital stay as well. And so similarly with outcome measure for our patient, OT as well, you can see the same similar theme here when done within the window as outside the window as well, and for speech as well. And so I want to end this presentation with some take-home points. And so first of all, it's really important to utilize the core outcome measure set after stroke so that we can assess the patient's recovery. It helps us to, it helps to inform our clinical practice and also the research that is lacking and where we need to go to bridge that gap in as well. And that tracking that compliance by using simple measures like just auditing the process once you implement something, just auditing how we are doing with how we are performing. That is important. But again, I wanted to also reinforce the fact that sharing the data, we have this is kind of like a QI team and bedside clinicians that alliance or the collaboration is very, very important, and that making sure that the bedside clinicians also understand the data that we are collecting on the audits that we're doing, that is crucial as well. And once we use this process to help improve our performance. So like I mentioned earlier, asking the staff to like, hey, what is working, what's not working, why are we seeing a drop in these trends? With I want to say like with SLP, there's one measure where they use the IOPI bubbles, and there were times when there was no supply of that, and the data dropped during that time. So that was reflective in the data, but once we supplemented the equipment, then the data went back up again. And so that sharing of the data, but also like using it to like identify the barriers and putting action plan and strategies into place is very important. And lastly, it's important to celebrate the success that we have with our staff. So just always kind of like reaches out to me in the beginning of the month and they're like, hey, when are we getting the data? When, you know, our staff meeting is coming up. And so, you know, the staff are asking for the data. So I think this is like, it's very important that we celebrate the successes and the hard work the bedside clinicians put in as well to help with the, implementation of the outcome measures for these patients. So thank you, and we'll take questions.